Hi everyone, it's Misty Marshall. In this PowerPoint, I'm going to do a quick review of the endocrine system, focusing primarily on physiology as well as assessment. And then your other audio and video prep materials will get into more specifics. This slide shows all the glands that make up the endocrine system. The ones that are in italics and bold on the left and also highlighted in the picture are the ones that we're going to focus on in block 2. The remainder you'll get when you get into block 3. The picture that's here shows the location in the body of each of those glands. And remember that the purpose of the endocrine glands is to produce and secrete hormones.
Hormones are chemical substances that are produced in the body, so they're created by something in our body, and they have a target. So they essentially control and regulate target cells or organs. Now, many hormones are going to be produced in one part of the body, but then they're going to control and regulate the activity of cells or organs in a completely different part of the body. So, for example, the thyroid gland synthesizes the hormone thyroxine, but then that hormone thyroxine is going to go and affect all body tissues. Okay. Some common characteristics of hormones is that they're secreted in small amounts at variable but predictable rates. They are regulated by feedback systems, which we're going to look at in a minute, and they also bind to specific receptors in the target cell. This table shows the different hormones and their associated endocrine glands, as well as the target tissue and the functions that will be relevant as we discuss the different disease processes that we're going to focus on for our Block 2 endocrine content. As far as hormone regulation, there are various mechanisms that either stimulate or inhibit hormone synthesis and secretion. These include simple feedback, nervous system control, and physiologic rhythms. We're going to focus on feedback mechanisms, but keep in mind that in addition to chemical regulation, the nervous system and things like circadian rhythm are also going to play a role in regulating hormones. Now, we said we're going to focus on feedback, primarily negative feedback. Negative feedback relies on the blood level of a hormone or other chemical compound that's regulated by the hormone, so like glucose. Negative feedback is going to be the most common type of endocrine feedback system, and it causes the gland to either increase or decrease the release of a hormone. So think of it in terms of a thermostat. You set a desired temp, and then cold air activates the thermostat to release heat, or hot air turns it off. It's the same kind of thing with negative feedback in the body. Okay, so we have a desired level of glucose that we want to see, and then if we have too much glucose in the body, then that's going to stimulate a process. Okay, and we'll get into more of that later. There is also positive feedback that happens in our body, but only a few functions in our body work on positive feedback, and you're going to get into those more in Block 3. Here are a few examples of negative feedback in the body. The first one, insulin secretion. Basically what happens is you have an increase in glucose that's going to stimulate secretion of insulin from the pancreas. So as the level of glucose goes up, more insulin is secreted. And then as the blood glucose level decreases, the stimulation for insulin is also going to decrease. Now, keep in mind that's what happens in the case of a healthy pancreas, but not necessarily what you're going to see happening in a patient with diabetes, and we'll get into more of that later. Another example is thyroid hormone. The hypothalamus stimulates the anterior pituitary gland to secrete TSH, which then stimulates the thyroid gland to secrete T3 and T4. The third example I have here is calcium and PTH, or parathyroid hormone. Low blood levels of calcium are going to stimulate the parathyroid gland to release PTH, which is going to act on the bone, the intestines, the kidneys to increase the calcium levels in our blood. And then the increased calcium level in the blood will then inhibit further release of parathyroid hormone. On the next few slides, we're going to look at some of the various endocrine glands. First of all, the hypothalamus. This is the switchboard or the circuit board, basically the control center for the endocrine system. Remember, the pituitary gland is referred to as the master gland, but most of its functions are going to rely on direction from the hypothalamus. So one of the things the hypothalamus does is to control pituitary secretions. There are two important groups of hormones from the hypothalamus, the releasing hormones and the inhibiting hormones. The releasing hormones, as the name suggests, stimulate the release of hormones from the pituitary gland, and the inhibiting hormones inhibit the release of hormones from the pituitary gland. The hypothalamus also contains neurons, and those neurons receive input from the central nervous system, and they create a circuit to facilitate the coordination of the endocrine system, the autonomic nervous system, and behavioral responses like anger, fear, and pleasure. The pituitary gland, as I said, is often referred to as the master gland because it controls many endocrine functions. It's connected to the hypothalamus, and remember that interrelationship is going to be very important. The pituitary and the hypothalamus rely on one another considerably. The pituitary gland is going to consist of two major parts, the anterior lobe and the posterior lobe. There's also a smaller intermediate lobe, but we're not going to worry about that for now. We're going to focus on the anterior pituitary since it controls the secretion of TSH, which in turn stimulates the thyroid gland to secrete thyroid hormones, our T3 and our T4. The anterior lobe accounts for 80% of the pituitary gland. It's regulated by the hypothalamus through those releasing and inhibiting hormones that I just mentioned. This picture provides a great overview of the relationship between the hypothalamus and the pituitary gland. It also shows the hormones that are secreted by the pituitary gland and then the target organs that they affect. And again, remember, for right now in Block 2, the only ones of these that we're going to focus on is TSH and the thyroid gland. And speaking of the thyroid gland, that's what we're going to talk about next. Hopefully you'll recall that your thyroid is located in the anterior neck in front of the trachea. Its size is going to be regulated by TSH from the anterior pituitary. The thyroid gland produces and secretes three hormones, our thyroid hormones, T3 and T4, and then also calcitonin. So let's look at our thyroid hormones first. There's thyroxine, which is the T4, and that accounts for about 90% of the thyroid hormone produced by the thyroid gland. However, our T3, our triiodothyronine, is going to be much more potent, and it has greater metabolic effects than the T4. Those two hormones are going to affect things like metabolic rate, caloric requirements, and also carbohydrate and lipid metabolism. And then don't forget that iodine is also going to be needed for the synthesis of thyroid hormone. Okay. The other thing that the thyroid gland makes is calcitonin, which is produced in response to high circulating blood levels of calcium. And calcitonin, what it does is inhibits the transfer of calcium from bone to blood. It increases calcium storage in the bone, and it increases renal excretion of calcium and phosphorus. So all of that then in turn is going to work to lower the serum calcium levels. So remember, calcitonin, calcibonin, it's going to pull the calcium into the bone, so there'll be less of it in the blood. Our calcitonin, along with parathyroid hormone, which we'll look at in a minute, work together to regulate calcium balance.
Here you can see the location of the thyroid gland in the anterior portion of the neck. It kind of wraps around the trachea there. Then the parathyroid glands, which look like the little kidney beans there on the right side of that photo. We're going to talk about those on the next slide, but usually they're arranged either within or behind each thyroid lobe. Now you can see 4 in the picture, and usually there are 4, but that number can actually range, and people can have anywhere from 2 to 7 parathyroid glands.
Okay, so like I just mentioned, the parathyroid glands are those kidney-shaped glands usually found in the thyroid or just behind it. They are self-regulating. Now, this is still a type of negative feedback. However, it's not controlled by the pituitary or the hypothalamus. The parathyroid glands just regulate and control themselves. What they do is secrete parathyroid hormone, or PTH, which you might also hear called parathormone, and its major role is to regulate the blood level of calcium. So the PTH is going to stimulate the transfer of calcium from the bone into the blood. It's going to also inhibit bone formation, which is going to result in increased serum calcium and phosphate levels. So like I said, type of negative feedback. What happens is When there's a decreased serum calcium level, that's going to stimulate an increase in PTH. So the parathyroid gland is going to secrete more parathyroid hormone. And then on the flip side, when there's an increased amount of calcium in the blood, then our PTH secretion is going to decrease.
The last endocrine gland we're going to review is the pancreas. The pancreas sits behind the stomach, anterior to the first and second lumbar vertebrae. It has both exocrine and endocrine functions, and for our purposes right now, we're only concerned about the endocrine functions of the pancreas. The islets of Langerhans, that's the hormone secreting portion of the pancreas, and there are three main hormones that are secreted here. We have glucagon, which is secreted by the alpha cells. We have insulin, which is made and secreted by the beta cells. And we have somatostatin, which is secreted by the delta cells. Glucagon, when the concentration of glucose in the blood falls too low, then the pancreas releases glucagon. And it acts on the liver to release glycogen, which is our stored sugar, into the bloodstream to try and raise the blood glucose level. So essentially what glucagon does is increase blood glucose by stimulating glycogenolysis and gluconeogenesis. So it's going to raise blood sugar. Now, insulin is our principal regulator of metabolism and storage of ingested carbs, fats, and proteins. And insulin facilitates glucose transport across the cell membranes. So I always think of insulin as the key that opens the cell door so that the sugar can get in. And when we have increased glucose, that's going to stimulate the secretion of insulin from the pancreas. And it promotes movement of glucose out of the blood and into the cells. So insulin lowers blood sugar. So if you can remember that, that's a good start. Glucagon will raise blood sugar, insulin will lower blood sugar. We also have somatostatin, and what that does is inhibit insulin and glucagon secretion, so that's going to play a role in regulation as well. This picture shows the pancreas in the top left there, that long tapered gland, and in the bottom right is a pancreatic islet. And remember that the islet of Langerhans is the hormone producing area. And when you look at this picture, you can see the alpha, beta, and delta cells that secrete those hormones.
The aging process is going to have many effects on the endocrine system. So we're going to see things like decreased production and secretion of hormones, altered metabolism and biologic activity, decreased responsiveness, and also alterations in circadian rhythms. So what happens is that sometimes the subtle changes of aging can mimic manifestations of endocrine disorders, which can lead to a missed diagnosis or a delay in treatment. Our older adults might also have multiple comorbid conditions, or they might take multiple medications that alter the body's usual response to endocrine dysfunction. So symptoms like fatigue, constipation, mental impairment often get missed in the elderly population because we just attribute that to be part of the aging process, and it could really be something more underlying that there is an endocrine problem.
Next, we'll review the assessment of the endocrine system. Endocrine problems can be the result of hyper or hyposecretion of hormones. And patients who have endocrine disorders often present with very non-specific complaints. And frequently, the onset of symptoms is quite insidious, and very subtle or vague symptoms often get attributed to other physiologic or psychologic causes. So it's going to be really important to collect as much subjective data as we can. So we'll start with past health history. Ask them, have they had any changes in weight or appetite, in their skin, their libido, their mental acuity, their emotional stability, or how's their energy level? As far as medications, we want to ask about both prescription and over-the-counter meds, also about the use of herbs and dietary supplements. It's also going to be really important that we ask them about the use of any hormone replacement therapy. And then we need to keep in mind that side effects and adverse effects of many medications can contribute to problems that affect endocrine function. So, for example, many drugs affect blood glucose levels, and that's important to know what medications they're on to see if that's going to be an issue. Now, as far as functional health patterns, there are some key questions. In your Lewis textbook, there's a table that you can refer to for that. As far as objective data, remember that with the exception of the thyroid gland and the testes, most endocrine glands are inaccessible to direct exam. So we have to rely on other physical exam findings as well as lab tests to give us the information we need when assessing the endocrine system. Now, the most common presenting problems that you're going to see in these patients include fatigue, weakness, menstrual changes, and weight changes. So as far as your physical exam, obviously you're going to want to monitor vital signs as well as height and weight, because many endocrine disorders will cause changes in those things, both vitals and weight, either weight gain or weight loss. Endocrine disorders may also cause changes in mental and emotional status, so we want to assess that. Skin, we need to assess the color and texture of the skin, the hair, and the nails. We also want to assess any wounds and ask how long they've been present, because some endocrine problems will delay wound healing. We're going to assess the head and neck, inspect the eyes for position, symmetry, shape. Remember, large and protruding eyes are associated with hyperthyroidism. There's a specific condition called exophthalmos, and you'll hear more about that in your other audio prep. You also want to assess visual acuity, and then remember that the thyroid gland is not usually visible upon inspection, so if it is, then that can indicate a problem. As far as other assessment things, of course you're going to want to do the rest of your typical physical assessment, but I've just chosen to highlight where you're going to find some of the key abnormalities that we're going to focus on with the Block 2 endocrine disorders that we're going to cover. And we'll get more into assessment specifics in class when we cover diabetes and thyroid and parathyroid disorders. And then also I wanted to point out, in your Lewis textbook, there is a table that has assessment abnormalities listed by system. So you might want to check that out as well. Checking for a positive Kavaz-Tex or positive Trousseau sign might be something that we would assess for with our patients who we suspect have hypoparathyroidism. And hopefully you will remember these tests because we talked about them during our fluid and electrolyte content. And we know that these tests are positive when a patient has hypocalcemia, and hypoparathyroidism is the most common cause of a low calcium level. So it's quite common that we see positive findings in our patients with hypoparathyroidism. On these last few slides, we'll look at labs and diagnostic studies for the endocrine system. Now, lab tests might include either direct measurement of the hormone level, or they might involve an indirect indicator of how the gland is functioning, because certain blood or urine components like glucose or electrolytes are affected by the hormone. So we'll look at the thyroid labs first. They might do a TSH level, thyroid stimulating hormone, and I have the normal value for you there. It's in red and it's in bold because I would like you to please add that to your list of labs that you already have as one that you need to memorize for our purposes in Block 2. So normal TSH level is 0.4 to 4 milli-international units per liter. Now, the TSH level is considered the most sensitive diagnostic test used for evaluating thyroid dysfunction, but they'll probably also draw some other things in addition to just that TSH level. Free T4 or free T3 levels might be drawn, and those are going to measure the unbound T3 and T4 in the blood. They might also draw total T3 and T4 levels and assess those, but they're not going to be as definitive as the free levels would be. As far as radiologic studies, they might do an ultrasound to evaluate thyroid nodules to determine if they're fluid-filled or if it's a solid tumor. They might do a thyroid scan, which would also be used to evaluate nodules of the thyroid. And the other test they might do in terms of the thyroid is a radioactive iodine uptake, an RAIU, and that provides a direct measure of the thyroid activity, and it evaluates the function of the thyroid nodules. And when they do that test, the patient's given radioactive iodine either orally or IV, because, as you'll recall, the thyroid is the only gland in the body that utilizes iodine. So they'll then see how much of that iodine goes to the thyroid gland, and they'll measure that with a scanner at certain time intervals. As far as labs and diagnostic studies for the parathyroid, we're going to do PTH levels, parathyroid hormone, and that's going to tell us how much PTH is in the blood. Now, we aren't going to just draw that, look at that, and look at nothing else. That particular lab needs to be drawn along with and interpreted in terms of serum calcium level. So they might do a total calcium, they might do ionized calcium, they might do both. Remember that the ionized calcium is the free form of calcium. But if we see hypercalcemia and also an elevated PTH, then that can indicate primary hyperparathyroidism. When we see hypocalcemia and a decreased PTH, that can indicate hypoparathyroidism. We'll also draw a phosphate level because we can't look at calcium without looking at phosphate because of their inverse relationship. And phosphate level reflects the inorganic phosphorus in the blood, and increased levels indicate primary hypoparathyroidism or maybe secondary causes like renal failure. When we see decreased levels of phosphate, that indicates hyperparathyroidism. And then radiologic studies, they might do a parathyroid scan where they use those radioactive isotopes again, because think about where the parathyroid glands are located in terms of the thyroid. So they give the radioactive isotopes, they're then taken up by the cells in the parathyroid gland, and then they get images of the glands and any abnormally active areas. And then finally, labs and diagnostic studies for the pancreas. The first lab here is fasting blood glucose. That measures the circulating glucose level in the blood, and with that test, the patient should fast for 8 to 12 hours before getting that blood work drawn. The next one is the oral glucose tolerance test. That's used to evaluate abnormal fasting blood glucose levels that do not clearly indicate diabetes. Maybe it's a little elevated, the fasting glucose, but not enough to say that it's diabetes for sure. So this might be the next test that they would do. With this oral glucose tolerance test, the patient drinks 75 grams of glucose, and then they draw several samples of a blood glucose level, like right after they drink it, 30 minutes later, 60 minutes later, 120 minutes later. So the whole test takes 2 hours to complete. And this is another one where the patient needs to fast for 8 to 12 hours prior to having the test done. Next is the glycosylated hemoglobin, or the hemoglobin A1C. That indicates the amount of glucose that's linked to hemoglobin. So this test is used to assess long-term glycemic control during the previous 3 months. So it's based on the lifespan of hemoglobin. And for this test, if a patient has diabetes, the ADA treatment goal is that they would have a hemoglobin A1C that's less than 7% and as close to normal as possible. Now, a normal hemoglobin A1C level for somebody without diabetes would be 6%. And then we might also test the urine for ketones, and that measures the amount of acetone, which is a type of ketone, that's excreted in the urine as a result of incomplete fat metabolism. And when we see a positive result, that can indicate a lack of insulin and also that the patient is developing diabetic ketoacidosis. As far as radiologic studies, they might do a CT scan, and that's going to be done to identify tumors or cysts on the pancreas. And with that test, they might do oral and or IV contrast dye with that.
And that's it for this PowerPoint. If you have any questions, please let me know. But otherwise, thanks, guys.